Hello, I'm Dr. Hui Shao. I am assistant professor at the University of Florida College of Pharmacy in the United States. Since this talk is related to one of my research projects, I would like to acknowledge my colleagues, Dr. Li Zhengxi, Dr. Vivian Fonseca, Dr. Bian Jiang, Dr. Ahmad Winterstan, and Ms. Yang for their valuable contribution. Well, it is quite an astonishing story, actually. Me, myself, is not a clinician at all. I'm an economist whose research field is leaning towards microsimulation. So my research is to use microsimulation model to predict the progression of diabetes and its related complications. So things were easier in this field 10 years ago. If you were able to observe a policy that reduced the blood glucose level in diabetes patients, you can claim that you are able to predict how many cardiovascular cases this policy will be able to avert based on the association between glucose level and the risk of cardiovascular questions. If you say you can do that, most of the people will actually buy your story because it seems to be a common understanding at that time. If you reduce the blood glucose, you reduce the risk of future cardiovascular disease. Then results from those three large trials were published, namely ACCORD trial, ADVANCE trial, and VADT trials, which all failed to demonstrate a lower risk of primary cardiovascular endpoints associated with an intensive glycemic control. Since then, if you go out and say, hey, I want to model the impact of a blood glucose lowering treatment or policy on reducing cardiovascular risks, many people will actually stand up and say, hey, the assumption that is backing your model is fundamentally wrong because those three trials have demonstrated that there is no guarantee a reduction in blood glucose can lead to lower risk of cardiovascular complications. And it is not just my field got influenced. These controversial findings from those three large trials also have divided the physicians community. Nowadays, many physicians still believe that there is cardiovascular benefit associated with the intensive glycemic control, especially among younger population. If you can make sure there's no escalated risk of hypoglycemia events associated with intensive glycemic control, it is still a good idea to push the patient's A1C level below 7%. However, a growing number of physicians start to argue that a moderate A1C goal is sufficient for keeping the cardiovascular risk at the minimum level. So instead of pushing the A1C level low, one should focus on preventing adverse events. The American College of Physicians even published its guidance statement on glycemic control in 2018, recommending a moderate A1C goal between 7% and 8% for the majority of the individuals with diabetes. However, the ACCORD, ADVANCE, and VADT trial really tells us intensive glycemic control lead to no cardiovascular benefit. Okay, let's take a closer look. In ACCORD, the hazard ratio of primary cardiovascular endpoints was 0.9, and in ADVANCE trial, it was 0.94, and in VADT trial, it was 0.88. So all the point estimates suggest a cardioprotective effect associated with intensive glycemic control, but the p-value suggests that those benefits are not statistically significant. So using the p-value to judge the significance of a difference is one thing, but relying on p-value to decide human life is an entirely next level. Thus, we feel obligated to offer an alternative point of view from a Bayesian school of thinking and reinterpret the results from the ACCORD trial and VADT trial. That is why we choose to do this study. So when we want to study something from a target population, we often acquire a sample of them, right? And based on observing subjects in this sample, we identified patterns. But as a scientist, we always want to learn something more than just the property of the sample, right? We want to find a pattern that doesn't just hold for this particular sample, but also for the population from which you took the sample. So this behavior is called inferential statistics. There are two schools of thinking in inferential statistics, the frequentist inference and the Bayesian inference. P-value is the centerpiece of the frequentist approach. It measures the probability of obtaining the current data given a null hypothesis being true. So in this context, it measures the probability of obtaining accord data given no cardiovascular benefit associated with intensive glycemic control. So having a p-value greater than 5% only demonstrates that the data fails to reject the null hypothesis. It does not mean the null hypothesis is true. So the Bayesian analysis, on the other hand, do not rely on p-value. So compared to the frequentist approach, which draws causal inference based on the current sample alone, the Bayesian analysis requires one additional piece of the information, the prior knowledge. So the Bayesian analysis combines this prior knowledge with the current data to generate the likelihood distribution of the outcome. So in this context, the prior knowledge refers to the likelihood distribution of the hazard ratios for MACE when comparing intensive glycemic control with the moderate glycemic control. And this likelihood distribution should be generated from prior knowledge in this field independently from the current sample. In this study, we test several alternative priors. We test the priors generated from the UKPDS trial. We test the prior from other cardiovascular outcome trial. We tested a non-informative prior, but most importantly, we adopted an innovative approach. We used a micro-simulation modeling approach to generate a strong prior. We used a Bravo diabetes simulation model, a simulation model our team have previously developed and validated to generate the likelihood distribution of the hazard ratios for MACE when comparing the intensive glycemic control versus the moderate dose. Through this micro-simulation model approach, the prior we estimated takes into account both the prior knowledge on the association between A1C and MACE, and also how heterogeneity in population characteristics might alter these associations. So for each of the ACCORD and VADT trial, we use the Bravo diabetes model to generate the population-specific prior and use the trials data together to conduct the Bayesian analysis and generate the posterior likelihood distribution of the hazard ratio for MACE for each trial. We have found that the intensive glycemic control appeared to be 99.9% likely to reduce MACE for type 2 diabetes patients based on data from both the ACCORD trial and the VADT trial. And based on the data from the VADT trial, we found that there is more than 50% likely that the intensive glycemic control is able to reduce MACE by more than 10%. We believe, based on data from ACCORD and VADT trial, intensive glycemic control is able to reduce the risk of MACE with 99.9% certainty. And we believe our interpretation on the results of the ACCORD and the VADT trial is more reasonable than a p-value based interpretation.